The key question behind the project I'm working on this year is how did Botswana's HIV treatment program get folded into a broader project of global health? Now, you might think, oh, well, this is obviously global health. Botswana had one of the highest HIV epidemics in the world in the early 2000s. It had a health system that was largely oriented toward primary health care, preventative services. It did not have a medical school, so its capacity to create new practitioners was limited. And it was in very dire straits in the early 2000s. And yet, at the same time, even as US-based philanthropic institutions and US medical schools came in to try to support HIV treatment in Botswana, they were coming into a place that had the fastest growing economy in Africa, if not the world, over the past 40 years. A place that had a stable transition to democracy, free and fair elections, and a health program that, even though it was oriented toward preventative and primary care, was still actually incredibly robust, right? It had the infrastructure. This was not sort of a blank slate that American institutions were sort of waltzing in and creating something out of nothing. So what ultimately happened was that there was a great deal of conflict over what global health was, who was doing it, and where I saw this most evident was in pedagogical practices. On the one hand, patients being educated to talk about their conditions in particular kinds of ways that clinicians at least believed would help them continue to take their antiretroviral medications. And on the other hand, interactions between American clinicians and junior physicians in Botswana, which were all sort of structured around the question of, if there's going to be a treatment program for this epidemic, who in the future will be qualified to treat that?